Dhamodharan, you can unmute yourself. Please unmute yourself.
Very good evening, sir. Today my topic is about anesthesia information management system. Introduction. Definition. The anesthesia information management system is a computerized system that collects, stores, and presents perioperative patients' data, mainly preoperative, intraoperative, and postoperatively. Why it is important? It is a traditionally anesthesia records are handwritten, prone to omissions, illegibility, and retrospective entry. The aims ensures real time, accurate, legible, and permanent records. Context components of aims. It has two components: hardware and software. Hardware is nothing but of our workstation with computer, networked monitors like ECG, pulse oximeter, NIBP, BIS monitoring, etc., and server for central storage and backup. Software modules for pre-op, intra-op, and post-op documentation. Decision supports tools such as alerts, drug dose calculators, etc. Integrations with hospital, the data, and third is the data captured by aims. It's in preoperative, we have demographics, history, allergy, ASA, and airway assessment. Interoperatively, it records continuous vital monitoring of heart rate, BP, saturation, ETC, O2, and temperature, anesthesia agents, dosages, routine, and timings, how much fluids you are giving, and blood products and urine output, events, intubation, extubation, regional blocks, and invasive lines. Postoperatively, it records back to PSU handover. Advantages of aims. It has the clinical accuracy and patient safety. It has a automated timestamped data capture. It reduces the missed entries and alerts for hypotension, desaturation, and drug overdosing. And it also provides medical legal protection, complete tamper-proof record, often HPPA and GDPR compliant. Quality assurance and research. It facilitates the audit, benchmarking, outcome reporting used in large-scale data analysis, supports evidence-based anesthesia. Resource management. It tracks drugs and consumable use, helps in billing and cost analysis. What are the limitations and challenges we faced in this aims? First one is the cost. Initial investment will be very high for the software, hardware, and maintenance. Training, anesthetists and nurses need adaptation, risk for reduced vigilance if over-focused on the screen. Technical problems, downtime, integration challenges with challenges, data overload. Too much information may hinder clinical decision making. Confidentiality concerns, mainly compliance with HIPAA and medical legal issues if data is breached. Evolution and future trends. Evolution. The paper, it's isoelectrical electronic records to network. While now we are recording in paper, from that we are converting into isolated electronic records to that the networked aims and fully integrated perioperative. Future directions, AI and predictive analytics, forecasting the hypotension, hypoxemia, closed loop system, automated drug delivery, ventilator adjustments, cloud-based aims, universal access, useful for resource limited settings, integrated with national database, quality benchmarks, and outcome improvement. Clinical conclusion, the aims, it's a modern backbone for the anesthesia practice. It offers accuracy, safety, and medical legal protection and research opportunities. The challenges remain cost efficiency and adaptation is inevitable. Future, it is the AI-driven, cloud-based, integrated perioperative information systems. Thank you, sir.
Okay. So the word anesthesia information management system itself is self-explanatory that earlier when anesthesia was started, People were just giving anesthesia. If you see the evolution of anesthesia through ages, it all started. What was the earliest method of providing general anesthesia?
The paper.
Historically.
We start writing in papers, sir.
No. What was the method of administering anesthesia during the early stages of evolution of anesthesia? When they found out inhalation anesthetic agents like ether, chloroform, what was the method of their administration?
The simple suspension mask will be used, sir. The mask will be used.
What was the mask used?
I couldn't able to pronounce it, sir. Suspension.
It's called Schimmelbusch mask.
Yes, sir.
It's a metal frame,
Yes,
the
sir.
cloth over there, and they
Yes,
used
sir.
to pour the anesthetic agent, especially ether. And earlier to the ether was the first was to chloroform, then only ether came.
Yes, sir.
Why ether replaced chloroform?
Oh my days.
Anybody else? Not interested in history? Ranjani, Bindhu. Chloroform naturally had some complications. It produced ventricular fibrillation even in young individuals and cardiac arrest. There were so many deaths because of that. Whereas ether was safe on the myocardium. It was not that dangerous. So people replaced usage of chloroform with ether by open drop method. Why the modern anesthetic agents cannot be used like that? Why can't you use sevoflurane or desflurane or isoflurane as an open drop? Other post-DA graduates who are there? Anusha, doctor, are you there? Dr. Kamal, are you there?
Sir, maybe these are saturated vapors.
That is related to saturated vapor pressure only. Okay. So the high saturated vapor pressure will produce a percentage of 22% of sevoflurane if you use it as a open drop, just like ether. Okay. So 22% of sevoflurane, if it is administered to the patient, what will happen? He'll have immediate cardiac arrest because the myocardial depression will be so much. Okay. That is the reason why the modern anesthetic agents require very specific calibrated vaporizers. So during that time, they were just administering anesthesia and observing what are all the clinical changes. And then once the case gets over, they just let the patient and ask the nurses to look after. No documentation of any intra or post-op events were done in the earlier stages. And the first person to introduce documentation of the patient's vital conditions intraoperatively and postoperatively, who was that person? Was he an anesthetist or was he a surgeon? He was a surgeon.
Surgeon.
Dr. Cushing, who described Cushing's syndrome, Cushing's reflex, all the neurosurgeon. Dr. Harvey Cushing was the first person to ask a nurse to record the patient's vitals like pulse rate, blood pressure, respiratory rate every 10 minutes in a piece of paper and filed it along with the case record. So he was the first person to introduce the documentation of intraoperative patient's vitals as well as any intraoperative events, whether it is positive or negative events. Like he used to say, right now I am making an incision on the cranium, scalp, I am opening the dura, I am now finding the brain bulging out. So all these things he asked the nurse to note down and recorded that. So that was how the first anesthesia intraoperative information system was started. And then there was another person called Noseworthy who made a regular thick cardboard paper chart where he printed all the details that have to be recorded instead of writing it with the hand individually. So there was a column to say name, age, sex of the patient, IP number, pre-op diagnosis, surgery, everything was given a blank space so that you can just fill up that, and the recording system was made a little more easier rather than the mundane, difficult way of writing each and everything. And these charts were used and compiled to then make a post-op audit of whether anything went wrong. They can pick out those cards and say how many cases of tonsillectomy had aspiration, how many cases of tonsillectomy had laryngospasm after extubation, how many cases of tonsillectomy had post-tonsillectomy bleeding. Like that, each and every individual surgery, they could do get the information and do some analysis or audit and introspection. Then came your advanced method of, so gradually this sort of record keeping improved little by little, and with the advent of computers we have become more lazy. We have to just feed the data and sit quietly with the patient, and everything will be taken care of the computer, and minute to minute variations in the patient's vitals are all stored in that machine. And then if you want, you can take a printout and then look into that, or it will be stored always in the data system of the machines, and then it will be done. So from intraoperative storage of information, this gradually went on to the preoperative assessment also, to make sure whether what is the ASA category of the patient, whether he is fit for the surgery, what are all the investigations done. So all the details were collected and stored in the computer in the preoperative phase. Then it transformed and went on to the post-operative phase, where the patient's vitals and the complications were all stored and recorded. So by doing all these things, you get the all the details that you want about the patient from the preoperative, intraoperative to post-operative phase. And this helps in reducing your physical strain of noting down everything, and also gives a permanent good record of all the events and the information about the patient. This is very useful nowadays to make an analysis, present a paper, or find out how you can improve your services and avoid complications in the future. Okay, that is what happened in the entire system of anesthesia information management system. Okay. And as you rightly said, why we are not adopting in each and every hospital? Because the hardware and software, the machines that are required to do this are quite expensive. Not all hospitals can afford. Of course, corporate hospitals with a lot of money, they are now able to do that. And if you see the evolution of your anesthesia machine, when we were postgraduates in 1970s, we started with the very simple basic Boyle's machine. Then it graduated to machines with more sophisticated vaporizers. Then once the workstations came into regular use, which was considered very expensive during our postgraduate days, now every hospital, even small hospitals, are able to buy the workstations with their automated ventilators and vaporizers, etc. In these machines, to incorporate the anesthesia information system has become more easier, because most of them are electronically operated and they have a computer-based system in that. So this helps in the recording of all the information that you want by feeding the data, and then all you have to make an entry, then automatically it will record the whole thing, and that will give you an idea about how to manage the patient in the post-operative system. So that is how the anesthesia information system has evolved, and that is what you have to mainly stress in your answer. And I'll just show you what are all the things that are required for this particular question. And So anesthesia information management system is a simple automated record keeping. It is nothing but the record keeping which are available now in only selected institution, which is because of the involvement of computer in our day-to-day practice. That is how the electronic health record system, when it is integrated into patient's perioperative care, then it is called the anesthesia information system. So it is a electronic health record maintenance of the patient, which documents patient's entire perioperative experience. That is the definition of anesthesia information management system. So it implements even for, it helps in building research and clinical benefits. And it is utilization is difficult because of the, as I said, cost. So if you go into the history of anesthesia documentation, the first people to do this are Dr. Codman and Harvey Cushing, who did the paper documentation of patients' physiologic status during anesthesia. And they asked their nurses to do that. And once computers became available in the 70s and 80s, there were interest to make the recording electronically by capturing the signals, store them, and you can retrieve them at any time, and formatting the perioperative data for the patient. So the first one was the Duke automatic monitoring equipment developed in the early 80s. And one of the first systems to interface directly with clinical monitors to capture patient physiological data. Nowadays, all the workstations come with a multi-parameter monitor. So if you connect that multi-parameter monitor to the automatic monitoring equipment or the information system, it will record all the vitals that you set in the monitor, which are displayed throughout the period of surgery. That will be recorded inside also. When you were doing it manually, there were chances that you can cook up. Sometimes, when you want to avoid any problem, after a spinal, you have a hypotension, BP drops down to 80 by 50. If the anesthetist is not sincere, he can need not show that hypotension at all. He could slightly give the ephedrine and bring it back to normal, and need not mention that hypotension at all, and how long that hypotension was there, what was the effect of that on the post-operative period, was there any renal delay or shutdown because of that? We could not find out. On the contrary, if it is an electronically maintained record, every record, if it is properly applied cuff and you get a non-intensive BP, it will automatically go into the recording. And when you retrieve it, and if there is a post-op renal issue, you can always pick it up. That it is because of the prolonged hypotension that was not taken care of properly, or fluids not given. This is the reason for that, and we can correct that mistake. So this is the most important advantage of the automatic electronic record health keeping, and the functions across the entire perioperative experience. So initially it was introduced only for intraoperative usage, but later on it was extrapolated to both preoperative and postoperative cases. So this is the Nagaswamy chart, which we as postgraduates used in those days. And we have to physically record the blood pressure here. The systolic blood pressure will be marked by an arrow pointing downwards, and the diastolic blood pressure with an arrow pointing upwards, and the pulse rate will be marked at a dot. So you have the numbers here. So we used to manually record. In those days, we did not have these regular multi-parameter monitors. So patient will have a sphygmomanometer cuff applied to the hand, and we used to sit close to the patient, and every BP reading will be done manually, as you do with the non-invasive blood pressure like today. And even for that, nowadays you have all these Omron and other electronic gadgets where you just apply that. You don't do the auscultation of broadcast sounds and then record the BP. Only the cardiologist, I find, use the older sphygmomanometer still to record the BP. Otherwise, most of them are switched over to the electronic equipments. And so this is the Nagaswamy anesthesia chart, and this is the back side of it. So this is the front side where all the details will be available, and this is the back side. And here you write down the total doses of drugs that is given. And here you will have to mark the time, and then say first column will be for induction agent thiopentone, second dexamethasone, then panchronium or galamine, then the analgesic morphine or pethidine, and then last column will be for the reversal agent. Like that, you have to mark and then make the total milligrams of drug that are given here, and then post-op notes, the recovery, time of exhibition, all these things will be written here. So these were all done manually. So this was then extrapolated to electronic method of keeping the records, and this was now used in both pre, intro, and post-operative phases. And it's either a standalone software product or an anesthesia module within the hospital's electronic health record system. This is the definition of what is being done here. And the software for each workstation is called a client and provides the clinician with the user interface that allows access to anesthesia record as well as central computer server that stores patient data. So it can be recorded within the workstation, or it can be stored in a centralized area, just like a telemonitoring. And standalone AIMS software on workstation handles collection of anesthesia data on the workstation, and then files periodically, passes on to the central server, which is called the client. If the AIMS is component of hospital electronic health record system, and if the front-end user is interfaces most of all the data file directly to the central server, this is called the thin client. That is, of course, you don't have to worry about all that. This is just for understanding in case in future you get all these things. So if it is shown here in the your workstation as well as stored in the central, it is called the thin client. If it is directly sent to the electronic health record in the central server, that is called the thin client. And the hardware component of AIMS is the computer workstation mounted on the equipment and mobile wheel towers with a vendor-specific hardware known as the keyboards and barcode, etc. This is how the components of the electronic health record system. The syringe pumps are also included so that you don't have to worry about at what dosage you are giving a TIVA or vasoconstrictor support. Everything will go into the record if you just enter the data. So AIMS hardware should comply with the hospital infection control also. So apart from anesthesia, it will also take care of the other conditions of the hospital care of the patient. And it is compatible with physiological device interfaces, sir. And it will help in now the usage is spreading so much that it goes into not only anesthesia, it is taking the holistic approach to take care of the entire patient. So a successful AIMS implementation requires minimum investment time and people awareness. That is, individual with sufficient expertise should be available. Of course, once it becomes a routine, just like how transition happened from the old anesthesia machine to workstation is happening, it will easily take place. And this is a picture for you to have a mental idea about how the AIMS is introduced into multiple levels. It can be a monitoring network device integrated with the monitors. It can be two monitor network device. So if you have multiple theaters, you can use all these things combined together. And perioperative documentation, it helps in the maintenance of this electronic records. Instead of manually doing it, you can always go from the machine direct to the which will take care of administered medications, fluids and blood products, clinical events such as anesthesia induction, patient positioning and lines placed, required documentation for billing and regulatory, everything can be taken care of, and other relevant data that are not captured in the automated fashion as strain of 4, supposing you use a nerve stimulator which is not used in a regular fashion, you can include that by adding the data to that. So the AIMS contain preoperative patient assessment also, and gives a display of patient photos, graphical tools for annotating images of dentition and other particular characteristics. For example, if you say patient is a anticipated difficult airway, the future is going to be like that. This anesthesia information will take a photograph in all the profiles of the patient and show whether the patient is eaten to less, short neck, or has any peri-Robin features. Everything will be recorded, and that will be giving a warning to everyone. You need not be taken by surprise that it is going to be an unanticipated difficult airway. So like that, it is going to improve, and already it has happened in the Western countries. It's all because that's what the textbooks say. So the other typical features of AIMS will be to pursue patients' previous anesthesia records. That also will be taken into care. For example, a family history of malignant hypothermia or a scoline apnea. All this can be recorded, and record review of systems and physical examination and documents and anesthetic assessment and plan also done by the AIMS method. And post-operative documentation using the computer workstation in patient's recovery is also very important. And the benefits of AIMS are very high. As I said, now it is going to be into each and every field. That will be helpful. This is too lengthy a one that can be cut short for your answers. And the obstacles that are why the AIMS is not being used is reluctance to abandon the paper records. And one main reason what I think of is the anesthetists don't want to reveal their laziness or their incompetence in monitoring the patient or getting into a problem later on. Once all these things become automatically recorded, unless you are vigilant and you are going to tackle whatever complication happens then and there, you cannot escape. That is what the thing is going to happen. So that is the reason why many people still don't want to adapt to that, because they can still escape if by saying orally, no, I was with the patient, I did everything what I could do, and still this complication happened. That cannot be happening if this routine monitoring comes into, and there will be medical legal concerns with this, and that is one of the reasons why it is not being actively pursued. And AIMS can result in positive net return in 4 areas. One is the most efficient staff scheduling, resulting in decreased staffing costs, decreased anesthesia medication costs. So if when all the medications are being recorded, how much is given, you will easily know that in some cases you have administered excessive medication. You can cut down on that and improve charge and billing capture, and increase hospital reimbursement from improved hospital coding. And the vigilance and accuracy of the practitioner's recall of patient variables. So, for example, some complication happens during an emergency cesarean at the middle of the night, and after 3 months, you are likely to forget what happened. But if you go through the records, you will still find what exactly the complication that happened, and you can pick it out. So that is another important, because this is a permanent record that will be available for any time by the click of the button. And AIMS also will help in clinical decision support. How it will do, it will impact the care process, such as adherence to clinical protocols and guidelines. So if strictly, if you just like those of you who have worked in the NABH certified hospital, before the start of the surgery, everybody has to introduce yourself, and the nurse will ask what are the blood loss likely to be to the surgeon, and what is the critical steps to the anesthetist. So just like that, you can improve the standard of care by incorporating a particular protocol and guideline, and the decision making also will be supported by a variety of alerts, reminders, or notifications to modify the behavior of anesthesia practitioners that can affect many perioperative processes, or correcting OR location errors, then ameliorating intraoperative hypothermia, restoring alarms after cardiopulmonary bypass, and improving beta blocker compliance. These are all some of the incidences that are given. I know one case where long back when we were in active practice, a colleague of mine was doing a pheochromocytoma excision case, and patient blood pressure starting itself was 200 by 120, and intraoperatively it shot up more than that, and the monitor was going on giving high pressure alarm because of the increase in pressure. And the surgeon was all the time looking up and looking at the anesthetist's face, and quietly the anesthetist switched off the monitor and started recording him manually so that the surgeon won't know what exactly the BP was. So all that cannot be done if you have the anesthesia information system in place. And secondary uses, it can help in clinical research and collaborative projects in this thing. And this will be the future outlook of if you want to use the AIMS. You can see this is the monitor that is attached to your outstation, and that will be the whole thing that will be recorded along with whatever happening. And this is how the picture of such recording will be there in the future. And anesthesia risk also can be analyzed using this AIMS. And the other approaches to find the root cause of morbidity and mortality, like where earlier it was CPOT, confidential inquiry into perioperative death, or ASA closed claim study, and Australian incident monitoring study. Now the risk factors associated with increased odds of dying within 7 days, where these are all the forms that were found out. And so by making a proper use of these AIMS, we can also assess the possibility of morbidity or mortality, and then try to improve the standard of anesthesia and reduce the all the post-op or intra-op complications by proper pre-op selection of the patient and the optimization of the patient. So AIMS is nothing but a step forward, and it's going to be the future in taking care of more close and intimate care of the patient, with the aim to provide the best quality anesthesia and care to the patient. Okay, so that is the aim of AIMS. Okay, right. So these are all, this is what I prepared was a very large extensive one, but once you go through the slides, you can pick out all the important points and make it more shorter for writing a theory answer question if it is asked as a full question in your theory exams. Right. Shall we go to the last topic? Who is presenting that?
Myself, sir. Good evening, sir. My topic is steps to conduct a randomized control trial, sir. Definition: randomized control trial is a study design that is the effectiveness of an intervention or treatment by randomly assigning participants to an experimental group or a control group. Design of a randomized control trial includes selecting a suitable population, that is a reference or target population, selecting a suitable sample, the experimental or study population, making a necessary exclusion criteria, those who are not eligible and those who don't wish to give consent, and randomization, and then dividing into experimental group and control group, manipulation, follow-up, and assessment. The basic steps include forming a protocol. It fixes the aim and objective of the study. It fixes the criteria for selection of study and control groups and sample size. Sometimes before a protocol is completed, a preliminary or pilot study have to be made to find out operational efficiency, procedural flaws, unknown effect, and acceptability of a certain effect. Selecting a reference or experimental population. Reference, it is a population to which the finding of a trial, if found successful, is expected to be applicable. It may be geographically limited or limited to persons in specific age, sex, occupation, and social group. Experimental or study population include, it is derived from the reference population. It should be randomly chosen. It should be representative of the reference population. The participant must fulfill the following criteria, which includes they must give an informed consent after having been informed about the purpose, procedure, and possible dangers. They should be qualified or eligible for the trial. Randomization, it's a statistical procedure by which we allocate study and control group. It eliminates bias and allow for comparability through the theoretically elimination is possibly by matching. It can be best done using random number table. Manipulation, after forming the study and control group, manipulation is done by deliberate application or withdrawal or reduction of suspected causal factor. Follow-up, it implies examination and control group subjects at different interval of time. Assessment, bias may occur from three sources. First, from the participant, if he reports that feeling better knowing that he is getting new form of treatment, that is subject variation. Secondly, investigator measuring the outcome with influence, if he knows the result beforehand, that is observer bias. Thirdly, bias in evaluation, that is investigator subconsciously give favorable result of outcome. To avoid the first bias, that is for subject variation, single blind trial is done that the participant is not known. Double blind trial is done that the investigator as well as the participant are not aware. Triple blind trial is the participant, investigated, and the person analyzing the data are not aware of that. The study designs, types of study designs in randomized control trial includes concurrent parallel study designs. The comparisons are made between two randomly assigned group. One is exposed and the other one is not exposed. Patient remain in the study or the control group for this duration of investigation. Crossover type of study design includes the patients randomly assigned for study and control group. Study group receive treatment under consideration and control receives placebo or alternative. After observation groups are taken off for elimination of any medication effect and the carryover effect. Then those where cases are kept in control and those where in the control are kept in cases. In economy, the total number of patients required, but it is not suitable if the drug of interest cures a disease. Coming to the consort. Consort is a consolidated standard of reporting trial. It's an evidence-based guidelines comprises a checklist of essential items for protocols and primary reports of randomized trials. It includes a diagram that documents the flow of participants through trial. The recent consort is changed in 2025. Initially, the consort of 2010 includes 25 items. Now it includes 30 items. They have added 7 items, revised 3 items, and deleted 1. Coming to the various topics or sections included in consort 2025 includes title and abstract, open size, methods, and results. The checklist of items included includes identification as a randomized trial, structured summary of the trial, design, methods, results, and conclusion. Coming to the open science, trial registration, which includes name of the trial registry and date of registration. Coming to the protocol and statistical analysis plan, where the trial protocol and statistical analysis plan can be accessed. The fourth includes the data sharing, knows where the individual de-identified participant data can be seen. Funding and conflicts of interest, include sources of funding and other supports. Objectives, which include specific objective relates to the benefits and harms. Methods include patient and public involvement. It gives the information about details of a patient or public involvement in the design. Trial design, which includes type of trial, allocation ratio, and framework. Changes to trial protocol, that is the important changes to the trial after it commenced, including any outcomes or analyses that were not specified. Coming to the outcome, it includes outcome, it includes harms, that harms are classified and assessed as systematically and non-systematically. It also includes sample size, randomization, which includes sequence generation, who generated which tells about the person who generated the random allocation, types of randomization, and details of any restriction like blocking and block size. It also includes allocation concealment mechanism, the mechanism used to implement the random allocation sequence, implementation which tells about the detail about the access to random allocation sequence, blinding. It gives information about who was blinded after assignment to the intervention. Example, participant, care providers, outcome assessors, data analyzers. It also includes statistical methods to compare groups for primary, secondary outcomes and including harms. In the result section, it includes participant flow, including flow diagrams, recruitment, intervention and comparatory delivery, baseline data, a table. In the baseline data, it shows the table showing baseline demographic and clinical characteristic for each group, numbers analyzed for each primary and secondary outcome by the group. It also includes outcomes and estimation, harms, and ancillary analysis. These ancillary analysis includes any other analysis performed, including as a subgroup or sensitivity analysis, distinguishing a pre-specified results. Discussion includes interpretation, protocol and statistical analysis, and limitations, which includes trial limitation, addressing sources of potential bias, if relevant, multiplicity of analysis. Thank you, sir.
Have you been given a topic for your thesis?
Yes, sir.
Okay. Is it a randomized control trial?
No, sir. It's a case
So what is
control.
the difference between the thesis given to you, the work that you are doing, and the randomized control trial? Sir,
here we are comparing two groups, sir. Like we have a control group as well as an experimental group, and we are analyzing both the groups and getting results for any disease or anything experiments we are doing, sir. In my thesis, it's about a full observational study, sir. Like
okay. Very good. Okay, so there are experimental, there is a comparative study, there is a meta-analysis or the cohort analysis. These are the three varieties of research that can be done. Okay, so the main purpose of randomized control trial is to find some improvement in what is already existing. Okay, by trying to do, for example, if people have been using ARBs, that is aldosterone receptor blockers, and if some new drug comes to control blood pressure, you want to compare the efficacy of ARB already, which is being used by so many, with the newer drug. Then you do a randomized control study by comparing these two groups. Or a new drug comes and you want to find the effect on a newly identified hypertensive who has not been on any treatment. You use a placebo and then you use the new drug and try to compare. Okay, so this is how you do the randomized control studies. And so first of all, you should have an object for doing a randomized control study, or you must have a question or hypothesis. That is a very important thing. So what is the acronym that is used to find out your primary question or hypothesis? Any idea?
Yes.
Have you heard of FINER and PICO? FINER, FINER, which is an acronym, or PICO, PICO. So when you say the steps, the first and foremost step is for us to find out the first primary question or the hypothesis that why we are going to do this particular study, and then try to collect the literature about this. Who are all the people who have done so many studies about this particular line or the topic that you want to do. Then the third step is to see what is the sample size you want to do the study in, because that sample size only will determine whether your study outcome is going to be useful to the patients or the public or not. And then you formulate the methodology of doing your study. How you are going to allocate the intervention, whether it is going to be a random, single blind, double blind, or triple blind, and then once you do that, you start doing the study, then collect the data on each and every patient. You set up a protocol to collect the data. And once all the data is collected, then you do submit that to statistical analysis. See whether your intervention is useful or not. And once you are satisfied with the statistical analysis and the result, then you publish your conclusion. And first give a discussion and then publish your conclusion to do that. So this was the way it was being done in the earlier days. And the consort, what is the expansion for that consort?
It's consolidated standard of reporting trials.
So people were publishing it in a very random fashion, but then they wanted to have a set pattern of publication of their study and the results. And that is how the consort guidelines were formulated. And whenever you want to publish your research paper, you have to follow those guidelines, and then only the publishing journals or the magazines will accept that particular presentation. Okay, so this is the small nutshell of this question, and I'll just show you what are the things to be written.